Welcome back, everyone. We are gonna switch gears again back to infectious disease. We have the wonderful Dr. Hussein, who's going to be going through a smorgasbord of infectious disease topics. And I will turn it over to you, Dr. Hussein.
Thank you. Hi, everybody. Hope you are refreshed from your mini break. My name is Abby. I'm one of the clinical associate professors at UW, and I do mostly clinical stuff and then a lot of medical school stuff. So nice to be here. A smorgasbord is right. We are going to go through a large variety of topics. So, again, you'll have all this information to use later, and the ID um, topic range is broad, which I'll show you in a second. So hopefully we can learn some things, have some fun while we're doing it, and then use this later to kind of just review. Um, just to start out, no disclosures. I have yet not become fancy enough to need to declare anything or I have any financial conflicts, unfortunately, but I do aspire to fill this slide one day. Um, so when we are thinking about the medicine boards and the medical content, there is a ton of stuff, and the ID is right here with about 10%. Now, this was just updated this year in January, so pretty updated there. So 10% of it ID, which is probably going to roughly go out to about 20 to 22 questions. There's a website down here if you all are interested and want to peruse all the variety of topics. You'll see on this next slide that it can feel very overwhelming because this is all pulled straight from the ABIM website of all the things that they can cover. But rest assured, all of these are less than 2% of the exam. And so you don't need to dive too deep. We're going to try to hit some of the main points that are kind of, highlighted here just to give us a broad area, but there's always more to learn and, we'll try to focus on what's important. So typically what happens is the any type of weird, atypical, rare bug is going to be a first order question, as in just like what's the diagnosis? Things that are common, things that we see all the time, are going to get more second order questions about diagnostic testing or treatment. And then for HIV, the focus really used to be on clinical manifestations, and I think you'll still have some of that, but also a little bit on treatment and prevention. And I think you all had a STI talk already today, so we won't be touching on that. And I think you talked a little bit about UTIs as well. So we'll focus on kind of other topics for now. So we're going to jump into some cases because that's the easiest way in my mind to learn things. And we're going to start off a little easy because I know you guys talked about UTIs today. We're going to have a little brief UTI question. So this is a 69-year-old man who is getting a pre-op evaluation before he goes to get a TERP for BPH, and he has no dysuria, no frequency, urgency, flank pain, fever, anything like that. And his medical history includes hypertension and chronic kidney disease. As part of his pre-op evaluation, they got a UA, which showed some nitrites and some white blood cells, and the urine culture grew over 100,000 E. coli. He's otherwise stable and doing well. So the question here is, what is the next most appropriate step in management? Give a couple of you more time to answer. Okay. All right. I love this split because it just shows you the complexity of these questions. So the answer here is going to be B, which is begin culture-directed therapy right before the planned procedure. Now, why? Obviously, I know for sure that we drill it into everybody's heads to not treat asymptomatic bacteria, but there are certain situations in which we would do that. In this case, this person is undergoing a urological procedure that's going to have some mucosal trauma. So a TERP would qualify for one of the very rare instances in which we would offer treatment. Now, the tricky part here is when do we do that treatment? And I'm going to just go back a slide so we can see the options. Um, So typically the recommendation is varied. And so I made this specifically a little bit vague, but the recommendation is right before planned procedure. Now, this could mean the day before if we're starting treatment in an outpatient setting, or it could mean an hour before surgery. If they're coming in, you could just give them a dose of whatever they need right beforehand. What we don't want is to treat for an extended period of time because studies have shown there's no benefit from prolonging that treatment. So starting something a week before is too early. Delaying and checking for sterility is usually not the option that we go with. So typically the answer is just give something that is targeted prior to the procedure. So it's a little tricky there, but I think a helpful one to go over just because, you know, we want to make sure that we cover it. And you don't need to treat past the procedure, right? So you would get a dose before the procedure, and then that's it. You don't need to do anything afterwards. Okay, great. Other populations that may come up that they may try to trick you with are, people who have kidney transplants, people who have diabetes, indwelling cats. Again, just focus on pregnant patients and folks going urological procedures that have trauma associated with them. Obviously, and if you all have questions, feel free to put those in the Q&A and I will try to check that as we go. Okay, so moving right along into our next case, we have a 74-year-old who's coming in with a second episode of C. diff in the past, ooh, sorry, in the past 3 months. His initial episode happened after he got clindamycin for cellulitis and was treated with a 10-day course of oral vanc. And when completed, he had resolution of symptoms. But 2 weeks after finishing, diarrhea has come back. He's afebrile, hemodynamically stable, and taking oral intake okay. You test the stool again, and it's positive for toxin. What of the following, or which of the following is the most appropriate next step in management? Okay. So lots of C, but some split still. Okay, great. So the answer here is going to be start oral fidaxomicin. And Fidax has been one of our mainstays of treatment over the last few years now, but the guidelines recommend this as the preferred choice for the first recurrence. Now, this does not mean you cannot do vanc again, but again, this is for the boards, and this is probably what they're going to want to see is that we're going to want to try fidaxomicin for anyone with a recurrence. And the thought here is that this reduces the risk of further recurrence compared to vanc. It used to be more cost prohibitive. I think right now that's not as much of an issue, but it's always possible. And again, oral vanc is an okay option with a taper to do for recurrence. But for your boards, we're going to say fidaxomicin. You only need to do something like IV metronidazole and Povank in severe disease, so not in this person who's otherwise stable, presenting and doing okay. And after a few recurrences, we do consider doing things like FMTs or, now their new rectal suspensions, which are great choices, but would be, after a few more recurrences. So first recurrence recommendation is to trial oral fidaxomicin. Okay, let me just make sure I'm not missing any Q&As. Oh, I think I answered this one. Okay, perfect. Okay. Next case, we have a 66-year-old who's coming in with 1 week of fevers, some abdominal pain and diarrhea. About 6 months post liver transplant now due to cirrhosis secondary to alcohol use. Had one recent episode of rejection that got treated with steroids. He is EBV positive, HSV2 positive, and CMV recipient negative donor positive. Other complications in past medical history, as we discussed, are genital herpes and ASLD pre-transplant. He's on a couple of medications right now, some tacrolimus and pred, and some Bactrim and acyclovir. Physical exam wise, he's febrile, but non-toxic appearing, but there's some epigastric pain, low white count, pancytopenic kind of overall. CMV PCR blood is negative, and has a negative stool test, negative C. diff, and negative culture. And the colonoscopy was done, and it showed some ulcerations in the colon with some biopsies pending. So the question here is, which of the following is the next best step? Okay. All right. So looks like most people here went for option A, which is start ganciclovir. And that would be the correct answer here. So why? So I think there are a couple of like buzz things that people like to do for this question. It's a popular question. But when we're thinking about our transplant patients, anytime we think of rejection, steroids, and especially if we see someone who themselves was CMV negative, but the donor organ they got was positive, we want to think about CMV disease. So there's a spectrum of disease that we can see here. There's folks who may just be viremic but asymptomatic. There's folks who come in with true CMV syndrome. They have the fevers, the fatigue, the aches, the leukopenia, the whole situation, and then they're also viremic. And then there's tissue invasive disease, which I would say is what we see more often. And this can be invasive in different areas, right? So you have GI, you have your pneumonia, which is a little bit more rare, but we see a lot of this in our immunocompromised hosts. Oftentimes, if we're going to see CMV, it's going to be within the first 6 months because that's when they have the most immunosuppression and are most at risk for that. The thing to remember is that sometimes with tissue invasive disease, you're not going to have peripheral CMV viremia. So just because that CMV PCR is negative does not mean they can't have CMV. So that is what we would want to think about in this situation. Obviously, we would send the biopsy and we would see those CMVs on pathology there. But that's something to think about and to be ready to do kind of upfront. You can use ganciclovir or valganciclovir. The issue here, as we know, is that there could be neutropenia, and in these folks who are already immunosuppressed, it's even riskier because they're already sometimes neutropenic. So just paying attention to that and making sure we're being careful. And like I said, this is just kind of the takeaway here is that if you see D plus R negative, you should think about CMV and keep that in your mind because that's probably what they're trying to get you to think about or guess. Okay, moving right along. We have a 28-year-old patient who is presenting to establish primary care. Comes in and reports that he has sex with men and has three sexual partners in the past 6 months. He uses condoms inconsistently, was recently treated for rectal gonorrhea, no history of HIV infection, is otherwise feeling well today. You have some basic labs, including your HIV screening test, which is negative, no HIV RNA, normal creatinine, negative for active Hep B, history of immunization there. So the question here is, which of the following is the most appropriate next step? Okay. So a couple of split answers here. A lot of people thinking B. Okay, perfect. So what this question is trying to get you to do is to think about prescribing PrEP. So that would be daily emtricitabine tenofovir. And the thought here is that this person meets a lot of different aspects of maybe a little bit higher risk and would benefit from some prep. So typically what we do is a true drug regimen, known as Truvada. There's some alternates if we need it, but again, this is typically what we start with. And we should be considering this in people who have sex with men, people who may be using any sex workers, all that type of stuff, folks who are in discordant couples. We want to make sure to talk about PrEP and offer it as an option. And it's pretty widespread now, but there's still folks who haven't heard of it or don't know about it. And so, always take the opportunity to share some of that information so that folks can make some decisions for themselves. The important thing before we initiate, which is part of the reason we had those labs, is you want to make sure you're checking someone's hepatitis status because tenofovir is also a drug that we can use for Hep B. And so we want to make sure that they don't have Hep B so that we don't cause issues. And then making sure that we're documenting a negative HIV test and a normal creatinine beforehand. Some of the other options that we mentioned on here are, for example, A is used for treatment. And then, you can always repeat HIV testing, but it's not necessary if you're thinking about PrEP because you just did it. And if they're negative now, you can go ahead. And we don't want to delay the opportunity to start PrEP and risk someone actually acquiring HIV. And because this person did not have sex within the last 72 hours, or there's not concern for a risk of HIV exposure in the last 72 hours, they don't need any post-exposure prophylaxis right now. But post-exposure prophylaxis is also something that they may ask you about. And just a reminder, we can use this for occupational and non-occupational exposures, but we have to start it within about 72 hours. Otherwise, it kind of loses its benefit. We typically treat for 28 days and we follow up with folks to make sure their labs are looking good. And this is usually a three-drug regimen, right? Because we are technically treating, so it's prophylaxis, but it's treatment prophylaxis, not preventative. So just some things to keep in mind there. Again, typically these are the type of focuses they'll do on HIV when we're talking about treatment and prevention. Just some other things to think about as we talk about screening. We want to make sure that we test all adults at least one time, and typically done with this fourth generation. If we are concerned about acute HIV, that is the reason to order an RNA viral load, right? Because that will be positive before everything else. So if someone is coming in ill and they have acute HIV symptoms, you would want to add an RNA to that to make sure that we catch it early. Some just little opportunistic infections to think about and review because they're always testable if needed. We want to think about pneumocystis pneumonia, cryptococcal meningitis, toxo, disseminated MAC, and then some other things we think about are CMV retinitis, Kaposi's. They're not going to ask you probably any deep questions about this or treatment questions about it. That's more of an ID board review level, but just knowing these different kind of diagnoses is helpful in keeping track and making sure that we know what any opportunistic OIs they might be asking about. Okay, our next case here is, and for those of you who like to keep count of cases because you want to know when the torture will be over, there are 12 cases total. So just keep that in your mind and prepare your energy accordingly, I guess. Okay, so we have a 22-year-old woman who wakes up and finds a bat flying around her room. She denies being bitten, and her parents can't find any evidence of a bite, and the bat has flown away by the time they are, talking about this. What is the next best course of action? Okay. So, oh, that was nice, fast answers there. Okay, I love it. Okay, so the answer here is we would immediately start PEP. And why is that, right? We normally talk about bites needing to be the issue in order for us to do things. But the challenging part with bats at night is that their bites are so tiny and they're hard to see. And so you can never confirm for sure if you got bit. And this is actually highlighted in a recent article. I think this actually happened a few years ago, but for some reason they posted about it recently. But it's about an 11-year-old who woke up with a bat on his face and around him, but there were no bites, and so it was kind of unclear. And so they did not take him to get seen immediately. And unfortunately, he eventually got sick. And by the time they took him to the hospital, he did not make it. So really, this just highlights the importance of making sure that if you're in contact and you're in an area and you can't keep your eyes on the bat. So if it's at night, if it's dark, you want to make sure that you go in and get exposed. Now, there are a few animals that actually carry rabies, and this is going to vary state to state. In Washington state, it's really just in bats, but other states may have other animals. But this is just a helpful chart to think about it and what you want to do. So, high risk animals, we always want to go and get checked out for. So, bats, raccoons, things like that. So, just keep that in mind. Speaking of animals, this is my old bunny. He's dead now, but originally when I had started these talks, he was alive. Anyways, animals, like bats, are a huge component of infectious diseases and they cause a lot of problems. And so, if you were to think about a rabbit, what is some type of infection that would come into play? Actually, I don't know that we have a chat to type that in. Hmm. Well, I will just tell you.
We've been using the Q&A people are
Oh,
posting in there.
okay, great. Love it. Yes, and this might be a review for some of you, so this is a great time to bring that back. Yeah, tularemia. That's what we think about when we think about bats. Obviously, or sorry, rabbits. There's other ways to get tularemia. Sometimes the question stem is you're mowing a lawn and you hit a rodent and you aerosolized and you got tularemia, so that could be something. But when we think about things like rabbits, that is what we think about. Okay. And his name was Kunta. And the vet told me that when he eventually died, that he was the oldest little like domesticated pet rabbit he's ever seen. He was 13 when he passed. So look at that. I had no idea we had hit a record. Okay, moving on. So we have a 35-year-old woman with no significant past medical history who came in with fever, fatigue, new onset right-sided heart failure. She had recently come back from a 3-month trek in South America and got a few mosquito bites while she was there. Since coming back, she saw a dentist for cleaning and then had a dental procedure about 2 weeks ago. Blood cultures are showing Viridin strep, and she had an echo that shows a vegetation on the tricuspid valve. What is the most likely risk factor for the development of endocarditis in this patient? Okay, nice. Okay, good. So no one thinks it's the bite from her trip. And I was like, oh, nobody picked E, but that's because E is not an option. Ha, that's funny. Okay, so the answer here is the history of recent dental procedures. So I think we know that it's a very big risk for folks who have underlining issues or risk factors um, that they could come in and if they had a dental procedure without prophylaxis, they could get infectious or endocarditis from that. So in this situation, even though her treatment was about 2 weeks ago, strep viridans can take a while to really hang on there and grow. So it's not abnormal that it took 2 weeks for that to result. I think sometimes when folks see this, they're like, well, the dental procedure has to be more recent. And that, yes, for sure. But for certain of these organisms, they take a while to take hold and it's a little bit more of a subish acute process. So not out of the realm if the dental procedure was 1 or 2 weeks ago. Um, so poor oral hygiene and periodontal disease is actually what's more correlated with bacteremia more than the dental procedures. But you can imagine if you have those and you're getting a dental procedure, then the risk is higher. Viridins is found in the mouth. And is indolent, like I mentioned, whereas something like staph may show up a little bit sooner. These are the usually the common bacteria associated with dental disease that you have here in this chart. And the thing to remember is when do we do prophylaxis for these people? Because they do love to ask about prophylaxis. And when we think about it, it's really two situations. The person has to be at risk, and they have to have a procedure that is also eligible. So in this situation, what makes somebody at risk? That would be anyone with a prosthetic valve or graft, anyone with a history of infective endocarditis before, anybody who's had a congenital defect that hasn't been repaired. And I think the important thing to know here is if you have a repaired congenital defect from childhood, then there's no need for prophylaxis. If you have one repaired within the last 6 months or unrepaired, then that's when we think about it. And then the eligible procedures for this are actually very limited. Really, we only do this for anything that is manipulating the gingiva, um, and if there's some type of incision of the respiratory tract. So, a transbronchial biopsy, a tonsillectomy. You don't need it for other procedures. And I think oftentimes we do try to broaden that because, of course, we don't want anyone to get sick. Um, and so we want to make sure that that is what's going on. And then good question in the chat. Did we miss something underlining for her? No, she did not. I don't think I added anything with underlining disease. Mainly it's just to highlight that you can still get it through dental procedures even if you don't have an underlining issue, but most of the time they will probably tell you this person has like a congenital bicuspid valve or something like that. So that's a great question. You are not wrong. Oftentimes there will be something there, but sometimes, I've had people who are otherwise healthy who get procedures and sometimes get endocarditis. So just something to keep in mind. But great point. Okay, let me just double check I didn't miss anything else in regards to this question. Okay, cool. Okay, great. So this, obviously, you guys can review later just to make sure that you have it because I think this does come up actually quite often. And then, as a reminder, prophylaxis for this is typically amoxicillin about 30 to 60 minutes before the procedure. If folks have a penicillin allergy, there's some other options there. We use Zithro, we use Keflex, so things to keep in mind. Hopefully, they don't make any question that complicated for you, but just in case, it's here. And actually, I think this is the hardest question of all if they were to give it to you on the boards. I'm not sure you all would pass. I struggle with this constantly, but is it endocarditis or is it actually just your favorite dinner, lasagna? Hopefully, we're far away enough from lunch that this hopefully doesn't gross you out, but for your viewing pleasure. Okay, so we now have a 22-year-old who is doing high dose induction chemotherapy for AML. They're treated empirically with ceftaz and vancomycin for their neutropenia, but all the cultures are negative so far. 3 weeks into his course, he's still on antibiotics, still fevering, and he develops a cough and some pleuritic chest pain. So they get a CT chest. And you look at the CT chest and you're like, oh, I wonder if anything is weird here. And you may notice some things, may look at it and question it. Based on this information, and the likely etiology of this person's pulmonary infiltrate, which of the following would be the best empiric therapy? And I think someone asked, where does this patient live? They live in Washington State. Good question. Okay, perfect. Okay, so a good split there. So the answer here is voriconazole. And what they're trying to get you to think about is aspergillus. And the reason for this is oftentimes in our folks who are severely immunosuppressed, they can get aspergillus just because it's in the environment, it's around us, so you can get it anywhere. And what they want you to look at is this air crescent sign on the CT, let me go back. So little air crescent sign here. And when you see that, and sometimes they'll use the picture, sometimes they'll say the word, but if they say anything about a halo or air crescent sign, someone with neutropenia, they are trying to get you to think of aspergillus. If they have samples, they may tell you that it's an acute ankle branching because that's what aspergillus looks like under the microscope. And you can have a variety of diseases here. You can have some non-invasive and some invasive things. And disseminated disease. So it can show up in a plethora of ways. Diagnosis is a little tricky because none of our tests are 100% perfect, but you can get something like a serum galactomannan that could be helpful if it was positive. But really, biopsy and histopath are more so the definitive form. And obviously, we know we can't always get that. So a lot of these folks end up getting treated empirically if there is concern. And the treatment of choice is VORI. You could use amphotericin, but because this is so heavily trying to show you that's aspergillus, the treatment of choice is voriconazole. And that's just the main point takeaway there about the sign. Okay. Make sure to, okay, perfect. Okay. So you have a 74-year-old now admitted to the hospital with a vesicular rash involving the left side of her face. The lesions do not cross the midline. She has hypertension and osteoarthritis, is otherwise healthy, not on any immunosuppressive therapy. Which of the following is the most appropriate infection prevention recommendation? Now, infection prevention and infectious disease are separate, but they do like to ask isolation questions related to ID on the board, so I thought I would just include one here for your benefit. Okay. Now, I did IP for until last year, actually, and I will tell you, VCV is always the most tricky one for some reason because it can be so complicated and it really varies. So the answer here is you would place this patient on contact precautions until the lesions have crusted over. And the reason for this is that there are various levels of disease, spectrum of disease that we do different things for, which is it's not fair to you all, but alas, that is the way. So for a localized herpes zoster in someone who is otherwise immunocompetent, oftentimes it will be contact because it's hard to cover the lesions. For this one, I made it specific. If it's on the face or eye, really it's very challenging to cover and people are more prone to touching. And so we do contact precaution for these people because obviously this can be, this can be spread through the vesicles and the fluid from the vesicles. And so we would do contact for this person until everything is crusted over. You may see folks in standard precautions, and that's typically is if it's a small dermatome, they can cover it. Then that's fine. But I would say oftentimes what you'd be tested on is they would be asking for contact, or if someone has disseminated zoster or if they're immunocompromised with localized zoster, the answer they're looking for is airborne and contact precautions. Because when you're disseminated, you have a higher burden of disease, and so there's concern for airborne spread. And so that's how you would decipher those. So localized, immunocompetent, contact, disseminated, or immunocompromised, think airborne and contact precautions. Okay, and hopefully that makes sense. Okay, so we're moving along so nicely. Okay. All right. Maybe I'll slow it down. Maybe I'm going too fast. I don't know. That's fine. I'm sure you all wouldn't mind a little extra time of freedom in between your talks, but I'll try not to rush. Okay. So you have a 34-year-old, otherwise healthy woman coming in for fever, myalgias, and diarrhea. And about 4 days ago, she underwent surgery with placement of saline breast implants bilaterally. On exam, she's pretty febrile, heart rate is high, low blood pressure. She does not look good, has a diffuse blanching rash over her body, but her surgical incision site looks good. Has a little bit of an elevated white count, some low platelets, elevated creatinine, and she's gotten a ton of cultures as her workup has started on fluids and on some broad spectrum antibiotics, and she's admitted to the ICU. After resuscitation, which of the following is the most important and appropriate next step? Okay, nice. Okay, so I think you all are thinking about this in the right way. So the next step here would be removal of her breast implants. And the question is, why? So in this situation, this person is probably dealing with staph toxic shock. And oftentimes when we think of septic shock, we think of the menstrual form, which is associated with tampons being left in and being hyperabsorbent, which is not incorrect, right? We want to make sure if we see someone in toxic shock, we want to make sure that we check for these things and make sure because it does still happen. But there's also non-menstrual related, and this is usually associated with more surgical procedures. And in this situation, implants is one of those things. We can also see it postpartum or other cutaneous infections. So the wound itself, right? The tricky part here is that the wound itself actually looked great on this person, but it's more so the toxin-mediated inflammation that's happening beneath. So even if you don't see anything on the skin, you still want to keep this in mind. In this person, the fact that she had a diffuse rash, she had shock, she was febrile, all these things are making you think of the toxic shock phenomenon. You can have other symptoms as well, but you don't need to have everything, obviously, for it to count. So quick response here with fluids, antibiotics, and surgery is what's going to help save our patient. Um, Typically, we see a variety of things. We can see thrombocytopenia, you can see real renal failure, all the things that are shock defined. We treat this, typically, people will want you to think about toxin production here. So something like clindamycin to inhibit the toxin production plus coverage for either MRSA or MSSA, because clindamycin can become resistant. So we don't want to do that as monotherapy, but we would do that as adjunct for the toxin production. They may also ask you about linezolid. I think it's technically fair game now because linezolid also inhibits toxin production. So if you don't see clindamycin, but you see linezolid, then that may be the right answer. And linezolid covers MSSA and MRSA, so you wouldn't need additional antibiotic coverage with that. So just something to think about here. Main points are making sure we're thinking menstrual, but also non-menstrual with people with recent procedures, making sure we're thinking about covering for the toxin production aspect and the correct things. Mhm. Then I also want to talk about strep toxic shock because that's also a thing and it has actually significant high mortality compared to staph. And this is typically from some invasive disease like a necrotizing soft tissue infection, but can also be post-surgical and important to keep this in mind because again, it's the same idea. We want to make sure that we do something for toxin mediation. You may not always get a rash in these people, but they usually are bacteremic because strep can kind of spread very quickly. And I'm sure you all have seen some of these cases, but just want to keep that in mind. So staph and strep both can cause toxic shock, looks a little different in their presentation. So because I included my bunny from before, I must also include my current pets that are alive because they are needy and they need attention. This is my dog, Noodles. He's a golden doodle, like every other person in the state of Washington has one. Um, but even though he's cute, he can also cause shock. Do we know what bacteria from dogs that we think about in folks that may have present with shock? I'm gonna let you guys put in your thoughts in the Q&A. Mm. Pasteurella, I like that. It's a good thought. Yes. That can definitely cause infection. But when we're thinking about big shock pictures, the bacteria that we think about associated with dog bites is Capnocytophaga. And pretty rare. We don't get it often, but there have been folks who, if you have an animal, if you have a dog and they bite you enough and you have other comorbidities and you come in with shock, capnocytophaga is something we think about. And it's important because it's hard to grow and to find in the blood. And so we want to keep it in mind so we can treat empirically just in case we don't see it in culture. So yes, that is one of them. Yeah, I see someone wrote capnocytophaga. Yep. So they're cute and they're furry, but they can also be dangerous. So, just pay attention to those things. Okay. So we have a 75-year-old who is hospitalized with 2 weeks of fever and malaise, 72 hours of delirium. So you can't get much history. You review the medical record, and it looks like they really haven't been seen by a doctor for quite some time. The blood cultures are positive for strep bovis, and the TTE is negative, but the TEE shows an aortic valve vegetation. At the end of therapy, what additional steps should be taken here? Okay. I like this because I feel like this shows that we've hammered home this point. So the answer here is colonoscopy. And the reason for this is because strep bovis has a strong association with colon cancer. And I would say from my own experience, every person I've seen with strep bovis has indeed had underlying malignancy, which is unfortunate. I want to address question E because repeat TEE. So the recommendation is after endocarditis treatment, we should get a repeat TTE mainly for baseline function, not to look at the vegetation because that may never go away. And so even if you diagnose endocarditis only on a TEE, we would not recommend repeating that at the end, but you could repeat a TTE. So that is why E here is incorrect. So if this was TTE, then yes, that would be a valid response. Okay, so the association between specific bacteria and underlying colorectal cancer is pretty decently studied. There was a study that did looked at a couple of different bacteria, and you may see here that there's other um, ones with high hazard ratios, but we don't typically think about those as much as because they are already they're presenting in people who have other reasons for mucosal issues, other reasons to have this infection. So the only two that we really think about and recommend colonoscopies for are anybody with Clostridium septicum, and anybody with strep bovis. So those are the two that you would think about. Most of the time they ask about bovis, but this is the septicum is technically within limits. So if they ask you about that, that's what you should be thinking about is colonoscopy for these folks. Okay. So we have a 60 year. Oh, let me just double check, make sure I didn't miss any additional question. Yeah, so good questions with the hazard ratio. This is why this is always a funny slide to put. So the reason is the population that typically, oh my God, no, I'm going forward. Okay. That typically has these other ones has other reasons for they either what's the word, have other mucosal issues that cause them. And they also happen so rarely that it's just not yet enough to make it a recommendation. So I'm not saying that you can't, but it's just not a guideline recommendation. So it's not a testable recommendation. Um, Bacteroides fragilis happens in a lot of our folks who have underlying cancers or mucosal issues for other reasons, our folks who are immunosuppressed and may have like issues, and people who have underlying colitis, things like that. A lot of those things you can see bacteroides in, but there hasn't, which is a lower hazard ratio. But again, it's just not as well known or well studied. So that is what we say currently. Now, this might change over time if we have more studies that show some type of relationship. But as of now, the only two that are recommended, that are guideline recommended to look at is Clostridium septicum and Strep bovis. So sorry if that is confusing. Hazard ratios and that stuff is not my thing, but I put it up here so that you guys are aware. And, like I said, maybe Gamela at some point will change, but we just haven't seen enough of it for that to be a recommendation. Okay, hopefully that answers your question. Okay, so we have a 60-year-old person presenting with shortness of breath and fevers times 2 weeks. And they have diabetes. They live in Arizona, and they come in with some bilateral crackles, some tachycardia, no wheezing, a little bit of an elevated white count. They have some EOs, and their chest X-ray shows bilateral infiltrates. Which of the following organisms do you think is the most likely etiology of the symptoms here? Okay. Perfect. Okay. So once they tell you in a STEM, they give you a geographical location, I would pay attention to it because usually it's them trying to give you some type of hint. So in this situation, the answer here is Coccidias immitis. And the reason for this is this person lives in Arizona, so dry, southwest region, and there's a lot of cocci there. And so we also see these folks in Southern California, New Mexico. Those are the areas that you want to think about. So cocci shows up with usually some pulmonary infiltrates as like primary. There's other places you can get cocci. We have people with osteo and other things, but again, the typical thing that they're going to think about and test you on is pulmonary, and the EOs is kind of part of a hint there. So anytime they say southwest, that is a buzzword that they're trying to get you to think. You can have a couple of different manifestations here. There's the typical valley fever, which is the cough, the arthralgias, the fever, obviously, and that's more of a subacute process. And there's also extrapulmonary manifestations, like I mentioned. Meningitis is something you can see as well in these folks. More usually, folks who are immunosuppressed or are pregnant will get more severe disease. There's a lot of folks who are walking around with asymptomatic cocci who've been, um, exposed at some point that will have positive testing but have never had symptoms. And for those folks, we don't do anything different. It's really just for those that are symptomatic and sick. Thank you for the comment. When in doubt, it's Coxie, even when you don't think it's Coxie. It's very true. Coxie can do a lot of different things, so always important to test and keep that in mind, especially in folks coming from specific areas, like this map shows. This is just a map for other endemic mycoses that they may ask you about that are geographically linked. So your cocci, you'll see right here, and then your histoplasmosis is going to be kind of up in this area over here. And then your blasto and histo kind of have some overlapping ranges. So your blasto is going to be up in this area. And then your cryptococcus can really be found in a lot, but important to note that it is usually up here in the Pacific Northwest. Now, I will say there's a caveat here that yes, this is how they will probably test it. They won't give you anything crazy. But in practice, because of climate change, because of movement, people going from place to place, we have seen some of these things kind of spread in different areas. And so in time, this map may look very different, but right now, this is what to remember and focus on. Some other rare pneumonia associations, in case they come up, just so you all have them. If they mention anything about birds or parrots, you want to think about chlamydia. If they mention anything about rodent droppings, I know it's hot topic these days because of that recent little cruise, hantavirus, is around and alive. And so if they mention anything about cabins or rodent droppings, that's what they're trying to get you to think about. And then tularemia, like we talked about before, can also cause pneumonia. And so, again, rabbit association there. So, just some things to think about for your review later to keep in mind, because if they ask you about pneumonia, it may be one of these weird, funky things they want you to think about. Okay. So we now have a 27-year-old, previously healthy person coming into the emergency room with 12 hours of headache, fever, and confusion. Their roommate says has been increasingly lethargic recently, has some neck stiffness, and is disoriented on exam. What antibiotics would we use for this person? Okay, great. Okay, perfect. So this question is obviously getting at this person has meningitis and what do we cover with? And the answer, as most of you have guessed, is, or not guessed because you obviously know, is vancomycin triaxone. The reason I just bring this up is just for a couple of points. Meningitis is something that they like to ask about, and so we'll talk about a couple of different treatments here. But what I want to point out is that the reason that we do vancomycin triaxone, right? Because really what we're trying to cover typically for meningitis is your gram negatives or gram positives like strep pneumo, your H flu, your Neisseria, all of which are covered by ceftriaxone, right? We don't really think about Staph aureus, MRSA, MSSA as a cause of meningitis. So then why are we adding vancomycin? And the reason for that is because we often think about strep pneumo with meningitis and without meningitis. And if you guys use every place has their own antibiograms. This is the one from our UW Montlake antibiogram. But you can see here in this little corner that with meningitis, there is a slight 2% chance that the ceftriaxone is not going to cover it. And so for that reason alone, it is our guideline for, I think, all places to do double coverage with Vanc and ceftriaxone until we know for sure if it's strep pneumo and when we get sensies. So that's the reason that we double cover that. Ooh. Um, and then there was another answer in there that people picked, which was vancomycin ampicillin, which is absolutely a reasonable response for folks who are immunocompromised, pregnant, or over the age of 50. So if you get a stem with someone who meets that criteria, this middle criteria here, immunosuppressed or over the age of 50, ampicillin is a great addition because we're trying to cover for listeria as an additional possibility. So regular bacterial coverage, vancomycin ceftriaxone, remembering that that ceftriaxone is 2 grams BID because we're getting CNS penetration. So again, I think that is too detailed of a question of a thing to challenge you with, but just in case it pops up, you want this to be BID as opposed to every other time when we use ceftriaxone, which is just once a day. So ampicillin if immunocompromised or pregnant, and then for post-surgical, you may want to think about upgrading to cefepime flagyl for more broad coverage for hospital-acquired infections. Okay, just a brief little meningitis review there. So just some other CNS pearls that we want to keep in mind. If you really suspect pneumococcal meningitis, dexamethasone is an option to add there. If we're thinking about more of a chronic or subacute meningitis, you want to think fungal or TB, maybe parasitic. Um, Anytime they tell you about freshwater exposure in the summertime, they want you to think about an amoebic cause of meningitis. So, the horror stories we say when people have brain-eating amoebas from the water, that is what they will try to get to you with that. And then, as I mentioned, brain abscesses are a little different, and the coverage for that would include metronidazole empirically if they were to test you on something like that. So those are just some additional CNS things that we want to keep in mind as we think through the process. Okay, so some additional pearls. We are done with cases, but just some other quick tidbits to go over. Because I mentioned my dog on my rabbit, I had to mention my cat, who's also alive. Her name is Iris. Cats are one of the biggest causes of infections, and so we're just going to do a little rapid fire situation here, and I want you guys to put it in the QA. So, if you have a cat that poops in a stem, what are we trying to think about? What are they trying to get you to think about? Toxo. Great. I love it. Okay, perfect. If you have a cat that is a little baby kitten, brand new, and is in the picture and may have scratched or bitten you, what are they trying to get you to think about? Bartonella. Yes, excellent. Love it. Cat scratch fever. Yep, great. Okay. Now, if you have a cat that bites you and then kind of dies, what? This is a little tricky. Which one are they trying? What are they trying to get you to think about? Rabies. Yes, exactly. Rabies. Dead cat, rabies. Excellent. Now, if you have a cat that is giving birth or had a stillbirth, what are they trying to get you to think about? I love this game. I think it's so fun. Where's my button? Okay, there we go. Okay, brucellosis is a good guess. So typically brucella is coming from raw cheese and other things, and pasteurella could happen in a cat's mouth. So this one is tricky. What they're trying, if you see any stem with a cat that is giving birth, or any animal really giving birth, they're trying to get you to think of Coxiella. And so this happens in animals that are having stillbirths who are infected. They will result in a stillbirth. And so the Coxiella is what causes that, and that can come to you. So important to think about there. Okay, now you have another cat that's dead, but kind of non-specific dead. I know this one's actually the hardest one because we talked about this disease before. We don't always associate it with cats, but it can happen with cats. Hantavirus is a great guess, but not for this one. So what this one is trying to get you to think about is tularemia, because there are ticks and fleas that are related to that. And so that is part of the what can come from a cat. So if they have a tick, they have tularemia, they can die, and then that's what they want you to think about. And then lastly, if you have a cat that's alive, but maybe coughing and looks a little ill. What are they trying to get you to think about? No guesses. Okay. Well, the answer for this one is the plague. So Yersinia. And this actually I have seen more than I thought I would see. So not kennel cough, correct. Yeah, so if you have a stem with someone in the prairie or there's someone out in a farm and they find a sick cat and then they come in sick, what they're trying to get you to think about is Yersinia, because that is why that cat is just coughing and sick. They may not usually be dead, but they're sick. And I have seen this 3 times, and each time the cat has been sick and someone took it home to take care of. So it does absolutely happen. So just a little refresher of all the multitude of diseases that your little furry cat feline friend can cause, but it's worth it, right? Okay, so there are some additional slides at the end of this that just cover some more pearls. We didn't talk too much about SSTIs, and so I just wanted to compile a couple of things that they may ask you about or mention, so just things to keep in mind here. Um, and typically in these situations, it's going to be like figuring out what the treatment or the next step is for this. The only one that's really more, rare here is Vibrio vulnificus, and that one is going to be one of those first order questions about like what disease is this? And this is something you can think about in someone who has gotten scratched in brackish water. If you see that, you can get that as a wound. Viral hepatitis, again, just typically some transmission questions may ask you about how that presents, and what that looks like. Always thinking about serologies and reviewing how to read those because we all know Hep B serologies are annoying. Most serologies are actually annoying because they're not always intuitive. And then just some things about liver abscesses. Typically, if they're less than 3, you can just do antibiotics. If you have a giant abscess, they're going to want you to think about drainage and antibiotics for those. And then always important, infections that do not require antibiotics, right? These are sometimes trick questions that come up. So asymptomatic bacteria or people with yeast in their urine typically doesn't need treatment. Hot tub folliculitis, so a stem where somebody was in a hot tub recently, coming in with pustules and nastiness, that typically is caused by Pseudomonas and oftentimes does not need systemic antibiotic treatment and will improve on its own. URIs and bronchitis, those are things to think about too. Again, unless there's evidence of a superimposing pneumonia, you don't need to go for antibiotics there. In general, things that are stable and viral, we know that we don't need to antibiotics, but they may try to trick you by asking some complicated questions there. Um, Someone asked, oh, for an abscess, can you use doxy? Yes, no, not there. I mean, that actually doesn't matter. That's for your studying later. Um, so for abscesses, can you use doxy empirically or should you wait? I think doxy is very reasonable, right? So if you're gonna IND this and drain it, doxy or Bactrim are reasonable answers there. There's always some resistance, and the thing with doxy alone is that, sometimes if it's something like group A strep, doxy might not work as well. And so we always think about doing something like Keflex, which has good MSSA and strep coverage, but hopefully it wouldn't be that complicated with too many right answers. Okay. And I think that is everything. The answer key for these is in the back. Feel free to review those last slides that we went through a little quickly. They're not associated, obviously, with a case, but I think just important tidbits for you to have as needed. And let me make sure I'll stop my share and make sure I didn't miss any questions in the Q&A. Perfect. Okay. Well, if anything pops up, if you all have any questions further or you just want to say hi, my email is here. And yeah, happy to be here
Thank you so much, Dr. Hussein. We look forward to having you next year. These are always fun and fantastic.
anytime. Thank you all. And if there are things you do want to see covered, feel free to let someone, maybe me or whoever's in charge, know.
Yeah. Please fill out the course reviews, which I will remind everyone at the end of the day, because that's how we will let our speakers know for next year.